today's presentation. So here Dr. Kramer and Dr. Miller.
So hi everyone, my name is Brian Kramer. I'm a third-year PEDS resident. I just can't take off my stethoscope for a moment. This is Andrew Miller. He's an intern pediatrician, and we have no disclosures. So, show of hands, who here has ever prescribed antibiotic or ranitidine or any sort of PPI? Everyone. Who here has ever felt pressured to prescribe an antibiotic or an acid-suppressive medication? Not many hands, actually. Okay, well, I've felt pressure in the past. You're so stonewalling me, yes. So we wanted to present an interesting article today about the role of early antibiotic treatment, PPI treatment, and H2 blocker treatment, and the ultimate development of allergic conditions. So we'll get started.
First, we have the objectives here. I'll spare you all from reading them out loud, but they're here on the screen if anyone would like to see ours. Essentially, we're going to use the PICO-TT format. We're going to talk about Cox regression analysis, and we're going to see if this is a good study or not.
So before we get too far into the details, there's a general hierarchy to study design with the top study categories, the most reliable and accurate being a meta-analysis. So that's a grouping together of many different analyses and studies into one article or one thought process to try to answer a question. And then, as you can see, everything falls down from there. So ours is a cohort study, so kind of in the middle of this study hierarchy, with animal research being the lowest, of course, on the study hierarchy. And so what a cohort is it's a population. So in this case, it's a population of children who are either exposed or not exposed to, in this case, certain medications. And what you look for in each group is whether they end up developing a certain outcome, in this case, allergy, for our study. So an example of a retrospective cohort study is you have a bunch of people working at a tire factory, whether they were exposed or not to whatever the toxin, you can say, and whether that increased the incidence of death would be an example of a retrospective cohort study, so looking backwards. So retrospective cohort studies are not pre-planned. There is no longitudinal component. It's all looking backwards. They are very efficient and cost-effective. If you are good at EPIC or whatever EMR that you're using, you can actually go back and in person can do one of these studies. And they're particularly effective for rare circumstances where it might be hard to find individuals who were affected by that exposure. For example, asbestos or uranium, or survivors of atomic bomb blasts in Japan. Those would all be examples of populations that would be hard to assemble otherwise, but looking back at a large database could be useful. One of the big downsides of retrospective cohort studies is you're not controlling for variables. You're not looking at every single detail, so there's possibility for confounds to take place.
As you will see, our study is gigantic. That's the advantage of using the TRICARE system. So any child greater than 6 months old is the study group. So you'll see it's going to be quite a big number. Also, we're not excluding that many kids because it's going to be any child that receives antibiotics or acid suppression therapy, which is probably easier to figure out which children did not have this because almost everyone gets this. So the comparison would be the children in the database who did not receive these therapies. Our outcomes is going to be the diagnosis of allergic disease, which again sounds very general. We'll hit the specifics later of exactly what constitutes an allergic disease. And the type of question we're asking is prognostic. For children greater than 6 months old who received these types of therapies, what was their prognosis, or as we'll talk about later, their relative risk of developing an allergic disease. As Dr. Kramer has already mentioned, this is a retrospective cohort study for a variety of reasons, as mentioned before. So really what this study comes down to is the microbiome. These are friendly bacteria that live in our gut. We're going to save you all and not go into in-depth at this point in the PowerPoint, since what we're really focusing on is analyzing the research study. But suffice it to say that recent literature that has come out is just highlighting an overabundance of the importance of the microbiome and its relation to health. There are a myriad of different articles from all sorts of different aspects of medicine that are starting to clue in on this link and the symbiosis that exists between our gut microbiome and our overall health. And so that's really what this study is going to be looking at, is how the administration of these anti-acid and antimicrobial therapies affect the microbiome, which in turn perhaps has some prognostic indications. So these are just some numbers I want you to keep in your head for later when we go back and discuss some of the results. So these are from the CDC. These numbers are the kind of general population numbers for some of these things. So number of children under age 18 who have asthma, 6.1 million, which is 8.3%. And so just go ahead and remember that 8.3% number is going to come up again in just a moment. So study design, we've already talked about TRICARE. This is the military EMR. As you can see, so the study was children born between October 1st, 01 and September 30th, 13, which, not surprisingly, is 1,190,396 children. And we're going to come to the exclusion criteria next, but after the exclusion criteria, there were still nearly 800,000 children enrolled in this study. They were enrolled from the 35 days of life till at least 1 year of age, but most were followed much longer than that. Here are the exclusion criteria. Children with enrollment less than 1 year, so lost at some point before their first birthday. Children diagnosed with an allergic disease within their first 6 months, and again, we'll talk about what that means. Incomplete demographic data, or if they had an initial hospitalization at birth that lasted greater than 7 days. That got them out of the study, but again, of our 1,200,000, those dropped it to 800,000. So as promised, here are allergic disease outcomes as by ICD-9. So there are the codes for food allergies, anaphylaxis, asthma, atopic dermatitis, allergic rhinitis, allergic conjunctivitis, urticaria, contact dermatitis, medication allergy, or other allergy. So pretty comprehensive look at allergic disease. And a positive exposure for us was children who were prescribed outpatient therapy that included histamine 2 receptor antagonist, proton pump inhibitor, or antibiotic, as defined by the American Hospital Formulating Classification. So they did some limited grouping of these different categories. So they split the histamine and the PPI groups into those who received therapy less than 60 days and greater than greater than 60 days. Antibiotics groups were split into less than or equal to 10 and greater than 10. Just as a little spoiler alert when we evaluate the study a little bit later, one thing that the study did not really go into was if this was 10 days of therapy from a particular course or if that was the total amount of antibiotics the patient received. And so there was a little bit of confusion in our analysis related to that. Some variables tracked, again, included the demographic data, the name of the medication, days supplied, and the age of the child after the prescription. So the math nerd in me decided that we needed a formula for this afternoon. So here is our Cox hazard formula, and we're going to break this down in just a minute. What the Cox analysis does is it is a way of determining the relative risk as seen from a study. So,
The hazard ratio.
Excuse me, hazard ratio, correct.
Yeah.
Sorry,
So
correct.
I'm saying relative risk, but the relative risk is a measurement, it's a different is the hazard ratio, right? But just to say the statistical is based on probability, right?
Correct.
Hazard ratio is more similar to the odds ratio, which is more odds.
Right.
So it's different from hazard ratio. Okay?
Yes, forgive me for my misspeak. This is a hazard ratio. Hazard ratio of 1 is no effect. A hazard ratio less than 1 is a reduction in the hazard. Greater than 1 is an increase in the hazard. The models were adjusted for prematurity, C-section, sex, drug classes, and significant first-order interactions. Some other things that we would like to have seen accounted for would be things like smoking, pets in the home. If you think of all the different things that can affect allergic disease, the list is long, and the ones that they accounted for were fairly short, and that may play into the validity of this study. P-values were considered significant at less than 0.0. So the Cox assumptions here are, again, and we'll get to this in just a minute, but the Cox, essentially if a patient has a particular hazard ratio, an assumption of the model is that that hazard ratio will at least be that amount, if not increasing over time, and so the curves will not cross. So our quick discussion of Cox hazard ratios here. So essentially what you see in the formula is we are looking for an outcome h of t. We have our function, which is h0 at time t, and then it's a logarithmic, or depending on how you solve for it, exponential function that accounts for the different variables. And so what you have is we have a function that describes the risk in the general population, which is h0 of t, and what you add is when you see the beta 1t, what you're finding is a different intercept here with respect to the outcome, which is h relative to time t. So, for instance, we could use these graphs. I made these up, but let's say that h0t is over the course of a year, the average person's desire to take a nap. h0t beta 1 would potentially be the average resident's desire to take a nap over the course of the year. They're becoming more and more tired, but they have an increased risk that never decreases or crosses the the general population line. It has this standard increase based off the y-intercept. We can then look at h0t beta 2, which is perhaps someone who trained before the APG-ME hour requirements rules. They are even more tired than residents today. And then h0t beta 3 is perhaps someone like Dr. Kramer, who recently had a child, and needs to nap a little more.
I think this is a wonderful way of putting it together. It's fun. But now imagine that this person that is the resident, right, the pediatric resident, is in a special rotation that is much more tiring. And add on that he has babies at home, and add on that, so if you add more variables to here, right, you might modify the hazard pretty much. Maybe what is making him tired is not the rotation that he is because he's in NICU, but that his baby is at home. And when you put two things together, one thing might lose power, okay? So put it two ways down, to
the formula?
The formula. Yeah, go back to the formula like that. So if you put it in here, this is one variable, this is another variable, this is another variable, this is another variable, and depending on the variables you put on your formula, that's what you're adjusting for, right? So maybe what's making Kramer tired is not that he's in NICU, what's making him tired is that he has a baby, right? And when you put 2 and 2 together, then you notice whoop, the NICU rotation loses power. And having a baby at home makes it, his chances to want it enough higher. See? So when you put the variables together in the same formula, that's when you adjust for the different variables that you are considering. That's when you put your compounding. That's when you put your different things that you're analyzing, right?
So what we'll see with relation to this study is all of the different things that increase the y-intercept of that hazard, which would be the exposure to these various agents. So again, to just recap, hazard ratios, greater than 1 is increasing your risk, less than 1 is decreasing your risk, as compared to that of the control group. So lots of numbers on the slide. We're going to highlight just a couple of them here. So this is the table from the study that is referring to the incidence of the allergic diseases relative to all these different things. So an important one to notice, you remember the asthma of 8.3 in the general population. Notice here that the total population incidence is 14.1. So a concern that we have is potentially that this study may already be finding more allergic disease because of the population they've selected might, for various reasons, be more predisposed to allergic disease. This number, of course, does not invalidate the study, but just seeing the study's percent population as compared to some other CDC guidelines, for instance, can give us some information about that. Some other numbers that I specifically want to highlight would be, if you look at atopic dermatitis, allergic dermatitis, allergic rhinitis, not surprisingly, those three are by far the most prevalent of the different findings in the study. So we move from incidence to the second major table in the study, which is, these are the hazard ratios. So you see, again, the characteristics on the side. Those are the ICD-9 criteria that were found on review of the EMR. And then we see children who were exposed after 6 months to either antibiotics, H2RAs, or PPIs, and their increasing hazard ratio or increasing risk for these various characteristics. So a couple just first things to note when looking at the table is that none of them are less than 1. They all indicate a positive relationship or an increased risk to all of these various allergic conditions. Of note, however, if you look at the confidence intervals, you can see that with peanut allergies and antibiotics, it dips below 1, and so it's difficult to make claims with respect to that interaction. And then seafood, all of these things could potentially be protective because all of the seafood ones dip below 1. I think it's unlikely. But you can see, so perhaps that doesn't tell us a whole lot about seafood and its interaction with these things. But of note, if you look at, for instance, PPIs with relation to milk protein allergy or cow's milk, you see that it's 4.43 with a reasonably tight confidence interval there of 3.48 to 5.65. And similarly, really PPIs with any food allergy, again, with the exception of seafood that we talked about earlier, show a fairly increased risk. Also note, if we go back and we look at asthma with antibiotics, we can see that that is a 2 times hazard risk there with an extraordinarily tight confidence interval of 2.05 to 2.13. We won't go through every number in the table here, but I think it is important to note that all of these numbers did show up positive with respect to the interactions between these medications and the diagnosis of allergic disease. So we all know that medications cause side effects in all sorts of different ones. The interesting part of this study, and that we'll get into now, is how applicable is this to us? Should this change how we use these medications as therapies? Should it change how we think about them? Does it give us, someone in our corner when patients are pressuring us for some of these various medications? So what do these numbers have as far as their impact on our clinical practice?
Thank you, Dr. Miller, and I do love to nap. All right, so at every journal club, we always go through these questions. I'm going to ask the questions and give you just a moment to think about them, and then I'm going to answer them. I'm not going to ask for audience participation necessarily. There's a lot of voices in the room. We're going to talk about internal validity at first. So the first question is, was the defined representative sample of patients assembled at a common point in the course of their disease? So yes, so the patients were all gathered within the first 6 months of their life before looking at it retrospectively, but there is an uncertain relationship between the exposure and the time to presentation. Did these patients get an antihistamine and develop an allergy 2 months later or 2 years later? It's not specified based upon the analysis that was given in the study. What was nice is that there was potentially a long retrospective period as the data was gathered from 2001 on, 2001 until I believe 2013 or 2014, 13. And one of the big advantages of a EMR system like TRICARE is that you get so many patients, over 1 million patients were initially investigated. And there's very few EMRs and health systems in this country where you could even get such a large number. Now, in some Scandinavian countries they do studies like this, but not so frequently in America. There is a possibility to try to replicate this with a non-military database, but it might be helpful to get multiple healthcare centers together to replicate the study rather than just one. If we try to do the study just at Carilion, I think it will be difficult. And I was curious how the military demographics compared to the general population. And fortunately, I only looked at the Army, so TRICARE is Army, Navy, Marines, all of the different branches of the armed forces. And in general, the population, the general population reflected what the Army's population was, with the big exception of African American population. There's a lot more African Americans in the Army than in the general population. So was the patient follow-up sufficiently long and complete? So yes, as I talked about, up to 13 years of follow-up, although some patients were followed up far shorter than 13 years. We don't know the duration of the exposure to the result, as we talked about. And also, if a child had a parent who was in the armed forces and then left, they would be lost to follow-up in that case. It's possible somebody had a child who was given antibiotics and then left the military a year or two later, and 2 years after that could have developed an allergy to peanuts. Question 3. Was this done in a blind or objective fashion? So yes, the study was not even a twinkle in anyone's eyes when these data were gathered. This is a retrospective cohort study, so no one, not the parents, not the patients, not the clinicians, knew of the existence of this study. It was only until after the data were gathered to a certain point in time that the study was then run using various computer tools and analysis software. And there's also, we did discuss, there's a possibility for some coding issues. So as we talked about, this was from an EMR. As you know, residents and attendings in the room know, there's many different ways you can code the same presentation. So you could call it rash, or you could call it atopic dermatitis. If the clinician is just looking back and looking for examples of children who are coded specifically with the term atopic dermatitis versus just a rash, then you're going to be losing patients who potentially had the same condition and creating a context. All right, so if the subgroups with different prognoses are identified, did adjustments for important prognostic factors take place? So not really. One of the big downsides of doing an analysis like this is it was done in retrospective fashion and only using the EMR. So it's not like you were doing a prognostic study where you could do a survey and ask 100, 200 questions beforehand. And there are a lot of factors that were not taken into account. Did some of these patients who have pets, did that lessen or increase the likelihood of developing allergy? Are you more likely to have allergic conditions if you live in a rural versus an urban environment? This study did not take that into account, hence creating confound. So, we could spend all day coming up with questions. That might be a fun exercise at some point, at least for Dr. Jaimes, about different things that we'd want to think about before doing a prognostic version of this study. I'm sure we'd have a lot of different questions to ask to try to sort out any potential confounds. And there's always going to be confounds in any study. You can't ask every single question possible. You can't get every second of somebody's life into the data. And then as Andrew talked about, there was attention paid to the dosing, but we don't know how time responsive that relationship was. Did the disease develop right then and there, a month later, or was it a year later? Was it 10 years later? That's not elucidated by this study. And then, for example, in the premature infants, if you look at this study, there was about a double risk of developing these conditions in premature infants than it was in full-term infants. So results. How likely are the outcomes over time? Questionable, and it's a large study, and which is one of the ways that we create power in the study in a long observation period. But these conditions can also develop later in life. They can develop after the study group has finished its data analysis. Somebody can develop a peanut allergy at age 18, and who knows if that had any effect from the ranitidine they got when they were 3 months old. How precise are the prognostic estimates? So this is one of the greatest strengths of a study with a large population, is that, as Dr. Miller was describing, there was very tight confidence intervals. If you try to do this study with 700 or 7,000 patients, those confidence intervals would likely be a lot broader and quite possibly dropping below 1 more frequently. So in our study, it was just really the species allergy that crossed 1, making the effect pretty much null. And that's what I talked about here. So can I apply this valid, important evidence about prognosis to my patients? So maybe, this was a good study and it was a good start. I'd love to see more analyses similar to this, and this is something that you can present to your patients, that there was this large study that was performed, and it did show this general doubling of your risk of allergic conditions. That doesn't mean that, it's still, going from, say, 1% to 2%, but we always learn about cost-benefit analysis, so, you want to do more good than harm for your patients. So and I believe Dr. Hart just sent out a study about preterm infants and H2 blockers, and I believe it was H2 blockers, talking about how they had very little effect on GERD symptoms in those patients. So if you have very little positive impact in prescribing ranitidine, and you have the potential to double the risk of, say, peanut allergy, it gives you something to think about. It gives you something to talk to the family about. So will the results change my management, and will my patients be better off? So I think so. As I was just hitting upon, it really does give caution to prescribing empiric antibiotics, empiric PPIs or H2 blockers, given that there's this risk. And will patients be better off? So if the results of this study are valid and we can reduce the use of antibiotics and acid-suppressing medications in instances where they're not warranted, then yes, this can definitely help the patients, because these allergic conditions can sometimes be very difficult on patients, on their families, and it can create incredible morbidity and mortality, especially for anaphylactic reactions. All right, were the methods for performing the test described in sufficient detail to permit replication? Yes, so you could kind of follow this study to a T and try to replicate it using your own database. As I talked about, there's far more information that one would want to know if you were trying to do a prognostic version of the study, but still, if you are good at EPIC, if you're Christine George, then you can go back and figure out how to sort.
Don't do it. So, I wouldn't waste my time doing this again, right?
Yeah. I'm not saying to do it. I'm saying hypothetically. I don't know how to do it.
So how are you going to do it there? What would you do to actually make this something? So you have another question to answer?
Yes. Roger. So this is a well-designed retrospective cohort study that gives some useful information to the pediatrician or pediatric specialist It does detail the risks and the benefits, and it gives caution, but it does need a well-controlled prospective study.
Yeah, I agree.
So, just that, let's make it a discussion. Okay? So let's start by saying, I don't think it's well designed. There is a lot of stuff that is missing. So tell me, what do you think is missing? They mention why, right? So I would disagree with the conclusion, like, I would not, like, based on this study, I will not say my patients could be allergic. You know? Okay. Let's start this discussion.
Yeah, so I totally agree with you. In the genetics literature, we have a healthy degree of skepticism about two potentially unrelated events that are occurring at the same time. So in genetics, you find a mutation and the patient has a disease, and you're like, oh, the patient has a disease. Well, maybe. So I feel that this publication, the authors were really overreaching a little bit to say that we should not be prescribing antibiotics or acid blockers in this patient population because of other literature that shows an association that they didn't replicate in the study. So the study would have been, if it had been planned differently, their hypothesis is that these medications are changing the microbiome, but there's no data that they collected showing that these patients have a different microbiome.
That's one point. Anybody have another point? So let's go to the tables. I like the tables. Tables help you see. First table. So the way you should do this, if you're going to replicate this, don't do this study again because it has a lot of thoughts, right? When we talked about, for example, can you have a relationship between the use of PPIs and cow milk allergy? And most babies will have the symptoms at the same time. It's very common to think that it's gastroesophageal reflux in the beginning. It's not a fault to try ranitidine. Whether the ranitidine gives them complications, I don't know. I mean, I think we have to be very cautious on making that as a hazard ratio. Is this a confounding? See? So that is not a conclusion you can trace yourself in this based on this study, right? They took all this data. Go back one. And for example, in this, well, there is one thing I want to show you. See, if you see the first stage of diagnosis, you see the median. So most of the allergies were diagnosed close to 1.5 to 2 years of age. So if you're going to do this study again, don't do what they did. They missed way too much data. There's too much misinformation. You have, if you look at the first table in your article, the first flow sheet that they show you, you have 1 million people, 66%, they could collect data. We know by our own experience, coding is going to be a missing data. Have you ever gotten this analysis from the insurance company telling you that you have to actually vaccinate your patient for something you already vaccinated your patient? They don't get it right. They don't get all the information that we actually have in the chart. So this is coming from insurance company data. How accurate it is? It does have missing information to start with. This is just for, for principle, it's not a good start, right? That's one thing. If you notice the flow sheet right here on the first flow that you have in your article, you see all these million people, and then you get about 66% of them, right? When you look at the prevalence of the frequency, I'll say in this case it would be an incidence because it is on time and they didn't have it before and then they developed the disease, so that's a new case. So this is an incidence, right? It's quite higher than the general population, just like Andrew was noticing. Dr. Miller, he said like the general population is 8.4, here is 14 for something, so the population is different to start with, right? So it's a different population. Somehow these people have more diagnosis, which meaning they're going to the doctor more. So that's one of the things. Then if you look at what they use to adjust their data, it's based on what they actually found on the chart, right? Which is C-section versus vaginal delivery, prematurity, that's it. What about family history? If you adjust these hazards, put the hazards 1, 2, 3. Yeah, if you adjust these hazards for family history, all these, they will not exist anymore, right? Because it's like you increase the odds of from 1 to 2, but if you adjust for family history, it loses all the power, I bet you, right? But they didn't do that, right? So we don't know. Many other confoundings that they needed to adjust. Breastfeeding, we know that already, right? If the baby was breastfed, maybe the allergies will be less. We already know that. There are many well-known predictors that we're not taking into account here.
I was looking at one of the figures was like separating H2 antagonists and PPIs, but they didn't really differentiate between different antibiotics. And so, like, if you're prescribing it, you're probably going to want to know what the different antibiotics you're going to prescribe and what the risk is from each one.
Yeah, they put though that was 64% penicillins and then 14% gentamicin, and they gave us the breakout of what the antibiotics were that they were exposed in the first 6 months, but also they didn't say what if the baby got it. They only say the length of time, but they didn't say what if they got it. They mentioned that when they were exposing, if they got another sepsis workup, when they were born, maybe in the NICU, and then another sepsis workup when they were 3 weeks, and then maybe otitis media when they were 3 months, and is that having the antibiotics over and over again actually increasing the risk or not? They didn't say that. How many times they keep that antibiotics? The other thing they did is that they explain it on the methodology. They put the data together in one category, right? They say that all of this was in one category versus have antibiotics, antihistaminics, and the PPIs are not in one category, and that's weird also. Like if you can, is it having ranitidine or is it having antibiotic, right? And then they somehow play with the data, but they didn't put it together. So if it's having antibiotic versus it is having antacids, right? Or where if you have antacids and antibiotics, the risk will be higher. They only talked about some people being exposed to more, but that's just description of the data, but they didn't cross it in the analysis. So I honestly cannot really say, based on this article, that you're doing any harm on this.
Yeah. A couple things I was going to mention. We talked about meta-analysis. I just want to give a caution. It's sort of put at the top of the pyramid, but if you've really looked at meta-analysis, it's a garbage in, garbage out situation unless it's very controlled. I've seen many meta-analysis, flawed Cochrane analysis. It depends what they include. It depends the type of study they include, the parameters they include. So don't just, meta-analysis, therefore this must be the pinnacle of studies. Absolutely not. I think seeing the retrospective cohort study, you see the limitations here are dramatic. But I try to not make perfect the enemy of good. I still think there's some things, yes, they didn't look at microbiome, but other studies have. Other studies have looked at. They didn't reference that their C-section, their premature infants had higher risk of allergy. Yes, they didn't standardize that. They didn't control for maternal smoking. A lot of other factors, but it's a limitation on the database. It's still a pretty darn good database study, and it's provocative for other things. If you're going to set this up again, you would ideally be able to control for many of those covariables to exist. One of the things I noticed is that they noticed that the H2 blockers together with the PPI, 1.6% of the patients actually had a higher increase of allergy. They did not, unfortunately, design as, the antibiotic with the H2 or the antibiotic, even though they're 0.7 and 0.2, they didn't tell us if they were higher or not. I think it would be interesting. So I think it's important it's still a useful study in my opinion. They based upon a lot of historical other microbiome data, well-shown C-section, vaginal, well-shown antibiotic, premature infants. They didn't replicate the study in terms of looking at DNA fingerprint, but still, I think in the big scheme of things, it's a pretty impressive number of patients, but they certainly could have controlled some of the variables better, especially with the EMR.
And I think you have to be careful with that because the fact that it's a big number of patients doesn't necessarily make it good,
right.
So you have to be very careful what, they took into account. They didn't even count for breastfeeding, and then we know that will modify the gut product.
Or duration of breastfeeding.
Or duration of breastfeeding, and none of that. So I would say, because of all the data that is missing on the analysis and because it's just a misinformation, it's just to start the article because of being retrospective, not being planned, not having the right variables test to be able to control it. All of that is missing information. Just based on that, this article is biased, okay? And then some of the conclusions might be just plain confounded, like the cow milk thing. Could be completely a confounder. It doesn't really mean that having PPIs will actually give them higher stomach allergy.
I would just add that a retrospective cohort is a great farm system for doing a good study. In other words, if you wanted to know how to set up a study prospectively, which would really give you answers, this is useful to kind of say, okay, what variables do I need to control? Yeah. I'd like to do a prospective study, enroll them in our system. You can really do a nice quality study.
So, do not replicate this data. Do not replicate this study because it's not good enough, right? But it gives you some ideas. For example, your follow-up could be 2 years. Your follow-up could be longer, 4 years. But most of the allergies were presented in the first 2 years. So you can extract data from this study to have good suggestions for the next one. But definitely based on this, you can say based on the studies with the gut flora and all of that, do not send all of this without any real reason. But based on this study, I wouldn't advise anything.
So I think it's just another point to kind of drive home. This brings back to what Dr. Doherty had said about not taking two things and having a coincidence and then associating them and making them cause and effect out of it. It doesn't exist. Before you even decide on your study, whether it's prospective or retrospective, or choosing your variables, designing the study itself, you again need to think about the question that you're actually asking and then the framework for that. They chose an incredibly complex set of diseases. They chose an entire family of diseases, all allergic disease, and decided to try to find an association between 3 different groups of medication. It's a very wide range. It's effective, not to, I could use a backwoods West Virginia analogy, but that's like shooting a shotgun in the sky at a group of ducks that were flying by, and you hit one, so, I missed that one. Yeah. So it's just far too spread. And if you're asking already ahead of time when you ask that question, not focusing in on a specific disease, you're asking to have error. So just again, in the future, if someone's going to design a study or come up with a question, make sure that you're pertaining to a more specific question. Because if you don't, it's too broad, you're setting yourself up for failure.
So this study is a good example for the confounder. So for example, I can understand the breastfeeding as a confounder because it will affect the variables and outcomes. Because if you have breastfeeding, we have less probability for reflux disease and less probability for infection in general, and less probability to develop all the allergies. But how can we understand family history? How can this be a confounder? Just to understand the confounders to avoid it. Next. So it should be the confounder should be related to both variables and outcomes, or?
So because we know already that family history is a very strong predictor of allergies. So if your mom has asthma, and your grandma has asthma, and everybody in your family has asthma, your chances of having asthma are higher or lower? Would you like to know that to actually say, well, is that you have asthma because your family history is strong for asthma or because you had antibiotics?
But the controls also will have the family history for all.
You don't know that.
If you adjust for it. But this is not a randomized control trial, you get it? So we didn't get a whole set of people and say, okay, you go on antibiotics, you don't go on antibiotics, and you're all randomized together, and then all the variables are distributed equally. No, this is people who have no distribution, and you follow them on time. You know the predictors, you know what will affect the outcome, in this case, allergies, and then you have control for those predictors you already know. There are many we don't know, but there's some we very strongly know. We know about breastfeeding, we know about family history, we know about smoking, we know about many other predictors that we should control. If we don't control for those predictors, you cannot make conclusions that whatever exposure you're studying is the predictor. See? So in this study, they only control for prematurity, gestational age, I think, prematurity, vaginal versus C-section. No, nothing. But you can always, you can always take a look, because remember here we just is learning. So everything is valuable because we can have discussions about everything, right? And that's what opens our eyes. If we discuss about things, then we'll find out more, right? For example, in food allergies, which, you're completely right, this is too broad, right? There are many things that will predict other, like this is like family history of having peanut allergy in the family, whether that will predict peanut allergy or not, versus having been exposed to peanuts when you're 4 months to 6 months to 9 months, which we already know will actually decrease the risk of having peanut allergy, right? See, so there are many different outcomes that is going to plan this ahead. Will specifically get that information related to whatever outcome we are looking for.
Can I make one comment?
Yes.
So there's any compounds in any study. You referenced the peanut allergy study. Who was the population? It was siblings of children who had peanut allergies. It wasn't every child, but now we recommend to get peanut early. Like, there's no perfect study, and but it's important. That's the starting point. That's the starting point to the next peanut study, where you take everyone and you give them peanuts at 6 months versus 12 months.
I think for us, one of the reasons we chose this study was, like was pointed out, there are a lot of problems with this study. And that happens sometimes when you try to ask really gigantic questions that get the ball rolling. I think for me, what's helpful is, we typically think of these three classes as something that we use all the time, and we, in certain instances, think about the risks of them, but oftentimes we don't necessarily in how we use some of these medications in certain instances. So I think for me, one of the reasons this study was helpful was as a reminder, does antibiotics cause a 1.51, hazard ratio for anaphylaxis? Maybe, maybe not. It might totally be power, but I think it certainly lends credence to even the benign things that we do as clinicians can have some effects that are difficult for us to fully appreciate, and we should just think about how we use all of our medications.
And remember that when you choose a study and you present it here, it's not your study. You're not defending your PhD doctorate thesis, okay? We are learning from it, and you like it for a reason. Everybody's talking about it, and you want to talk about it, let's talk about it, right? But it doesn't mean that the article needs to be the best article in Earth ever created. No, I mean, we can definitely get the good things and the bad things, and this article opens questions, and this article might guide you on when you're going to really design the study to do it right, but you have to be cautious on what conclusions you make. And the other, I want you to think about something here. Like this hazard ratio change, honestly, it doesn't give me anything. You're increasing the risk from like let's say it was controlled to everything. All these confounders that we're talking about that are so strong, well controlled, and you still have a little effect. You still have a little effect. The effect that you have and the amount of you get more disease on this hazard ratio is not very impressive. And I tell you that just compare, for example, with smoking in a seat. Like if the family smokes, you have a higher risk of having sudden infant death in babies, right? You have 3 times higher risk of having a sudden infant death in baby. If you go sleep with your baby, you have 12 times more chances of having your baby dead, right? So will you sleep with your baby in the bed? You have to think about it higher, right? Because you are increasing the risk of death 12 times. That doesn't mean that every time that you sleep with a baby is going to die. You know what I mean? So you have to be careful how you interpret this data. I'm just putting some things around. I'm just putting some examples around. If I'm going to modify my risk of this baby to have allergies in 0.2, because it's 1, but then I increase the risk of 102 or 105, but the kid is having otitis media, and that can get mastoiditis and meningitis. Okay, I'll still prescribe my amoxicillin. Do you understand what I mean? So you have to really be sensitive of what is, even based on this huge database, and based on everything they did not control, that I bet you if they control to 2 of those things, breastfeeding and family history, none of that will have any value. But let's say they will control it. Even controlling is not that impressive. I'm not saying that there is no plausible reason to think that using antibiotics antibiotics or using antacids will alter the flora. We already know that. We also have plausible reason to know that if we do that, we have more allergic disease. But this study doesn't really give much of more to that. I'm sorry.
All right, don't worry. We're going to jump from soapbox to soapbox. I'm only getting on my last journal club. So anyway, I actually do agree. You know, all these points and all the flaws that are here, I don't want anyone here in future journal clubs to be discouraged or to choose these. This is actually a great study for journal clubs because it's good for everyone to learn how to expose the flaws that are here and discuss those consequences, because later on when you're out on your own, you need to be able to then adapt these and insert these studies to your own practice. And if you don't know how to actually break down and critique these studies and know whether you should add them to your own practice, it takes away from that. I will say, I think despite all of the flaws, I actually think they may have gotten across their ulterior motive, which is discussions out there now, because now there are people that are skeptical, but the article's there. This gets people talking, and it may provide for future studies, because other people now need to prove whether this is something that's real. So that's a good thing. So yeah, again, I think this is a good choice, guys.
One thing that I want you all to remember from this journal club is confounding, predictors. Did I adjust for all of them or not? And that will give you the answer, should I keep on reading this article or not? Is this article something I can have an answer or not? So that's the bottom line. Confounding, predictors, variables, right? If they didn't take into account what you already know, then we have to be very cautious what conclusions we have, right? So this open book of other studies to come, it will be prospective. It could be an EQ cohort and see what happens to them. They have very good EQ cohorts. It can actually be, followed for 2 or 4 years, and then we'll have some conclusions. And they can do a little bit of markers. They can do a little bit of testing on the bellies, see the flora, and then adjust for family history, adjust for breastfeeding, and see what is the real effect of the exposure of antibiotics and PPIs and acids.
So just to echo Jeffy's point, studies like this, I think, have a lot of utility in kind of exposing the tip of the iceberg. So, for instance, something like autism, we don't know what causes autism. We know some risk factors, but we don't know what causes autism. If you could look back and find a study like this and find whatever pops and then study that further, I think there's value in that. I think that helps direct your future study. And, very well, it might be just a confounder. It could be some error in the data. It could be, the dogs they have in their home. Who knows? It could be the water that they drink. But when you look at enough variables, it opens up doors for future study, and I think that's really the utility. And then the other point I wanted to make is, with all that's been said, take, for instance, antibiotics and asthma. Right now, it's 8% of the population, so that's 1 in 12 roughly. And then if you're doubling the hazard ratio, so that's 16%. That's basically 1 in 6. If you're on the fence about treating your kid's ear infection, it's probably viral, and you tell me that, my kid had a 1 in 12 chance, now he has a 1 in 6 chance of developing asthma. And even if the study's not perfect, even if it's completely flawed, it would give me caution. Now, if it's, looks like a bacterial otitis media, then sure, treat it. But if there's some doubt there, I think it adds more to the equation. Whether it's faulty data, whether it's garbage in or garbage out. Important to think about. Any other thoughts, Dr. Hart?
No, just the comment. I think we're learning a lot more. I do think that the connection, the microbiome stuff, as I said on the blog, we're seeing a lot of this stuff. Why is appendectomy protective in some of the patients with ulcerative colitis under 2 years of age, but actually worsens the risk of Crohn's disease? Antibiotic exposure in the first 2 years of life significantly increases your risk of Crohn's as an adult. It's clear that there's a lot of dysregulation. Microbiome plays a critical role in the whole immune system, and we think, just if you look at it from a practical standpoint, the incidence of autoimmune conditions and reactive airway disease and so forth, it's dysregulation technically. And so it's without a doubt, I think we're learning a lot more. I think the microbiome plays a huge role in this thing, but the mechanism itself remains to be elucidated. Great presentation. Thank you.
Thank you.
Other questions? Thank you.